algorithm. Hematochezia, a lot of times people, you can imagine with these staple firings on the bowel, they'll get some bleeding into the lumen of the bowel. Post-op day 3 or 4, they have a big raspberry or mulberry, whatever colored poop. It's old blood. You know what I mean? They look fine. They're about to go home and they had this big bloody poop. So usually that's old stuff that's worked its way through. So don't panic, but we will usually check a hemoglobin, and sometimes we'll keep them overnight, but it depends on how they're doing and how far they're going away. Very slow, obviously, with liquids only. Sometimes people will get a big thing of ice and they feel so dry after surgery. You got to be careful not to just give somebody endless ice. They can overdo it that first night if they're just, you know what I mean, shoveling in the ice chips. So
dietary, you'll go
well,
kind of like
again, it's not dietary's job so much as you guys not to overload them on the ice chips.
Like as far as what you're going to do is for advancing
Oh,
diet,
yeah,
it would be slower than the general surgery.
They're all going to go home on just liquids.
Okay.
And it's going to be protein-rich liquids, but it's a couple of weeks to let things heal, and then they get into yogurt and cottage cheese and real mechanical soft, and by 2 to 3 weeks, they're eating some, you know, going from baby food to soft mechanical, but we take it real slow.
What's the average length of stay then?
The average length of stay for a sleeve is going to be 1 night. For a bypass, it's probably going to be 1.5 nights. About a third of my patients in Duluth went home after 36 hours, and about half of them went home after 2 nights, and about 1 in 6 would stay a third night. Yeah, but it's not. They don't make it that. They're not that far along the diets. It's popsicles and broth and ice chips, and then we start to get them on the Carnation Instant Breakfast. But sometimes that milky stuff is just a little sweet. They're not going to run out of protein in 2 or 3 days, so we don't have to get them too far along. It's hydration, pain control, ambulation are the main things that get you out of the hospital. Okay.
So then, what about? Maybe you're getting to this, but what do we teach them as far as their bowel movements then? What to expect?
I don't worry about bowel movements too much, and sometimes people haven't even passed gas by the time they get out of the hospital. As long as the liquids are going down reasonably well, the rest of the gut is going to function, and certainly I don't worry about bowel movements.
And when they go home, they wouldn't expect to have formed stools?
Usually not. Usually not. If they need some milk and magnesia, that's okay. Sometimes people do get dry and they get constipated. Milk and mag is, I'm definitely not a Reglan guy. I think it causes cramps more than anything. If they're having nausea, they just need to go slower usually, or a little Zofran more than anything. Yeah. Pills, usually cut rather than crushed. People hate taking dust, you know what I mean? But main thing is not to give them, you know, and that's my job, is not to write for all their pills. I used to use Lortab Elixir a lot. That can be nice. But people are getting more liberal about letting people have pills. Don't panic about it, but just remember that it can be an issue, and to go slow with them. Liver labs, I've only seen this a few times because I don't usually check liver labs, but it was when hospitalists were involved and they got a complete metabolic panel as opposed to a BMP. Well, we elevate that liver with a retractor, you know, for a good hour. The next day, the LFTs bump, and sometimes they're up for a couple of days. Don't panic. You may hear about that, about LFTs going up. We talked already about very rapid change with their blood sugars. For the most part, it is sliding scale, and about half of the dose of the metformin that they came in on. None of the glyburide, none of the things that are actually hypoglycemic causing oral meds. Okay, insulin. It's pretty much insulin and metformin for most folks in the short run. Now, once they're 2 to 4 weeks out, you know, we'll tune things back up a little bit. But that initial period, we want to be really cautious. All right, I've only got about 3 minutes for the late stuff, but I want to talk because you guys are going to see the readmissions as well.
You can go on a little bit more.
Okay, well, yeah. I can cover it pretty quick too. So, be very careful about late readmissions. You can have people back 20 years after a gastric bypass with abdominal pain. A weight loss surgeon needs to be involved, or at the very least, a surgeon needs to be involved. This is not your regular old small bowel obstruction. You can get a little closed loop bowel obstruction through an internal hernia. It doesn't show anything on CAT scan until that bowel dies. You do not put an NG tube down somebody in that little pouch. You can put that NG tube can poke right through that roux limb. Okay, because you know, huh? Never ever. Yeah, I mean the only place for an NG tube is to be placed under direct vision endoscopically, you know, in the OR with a scope or in the endoscopy unit with a scope. Occasionally we'll put feeding tubes down, but again, usually with a scope guidance. But those soft feeding tubes, that's a different deal. But a bowel obstruction is not decompressed. About 30 to 40% of bowel obstructions in this country from other causes go to the OR. More than half of them go home, right? They get better, they go home. With bowel obstructions after gastric bypass in particular, more than 60% go to the OR. So it really is a different deal. We also do chronic abdominal pain workup sometimes. Just exploratory laparoscopy really is an invasive test. Now, it's not the first test we do, but sometimes we'll just have to go have a look. There's more stuff in there than I can talk about in the scope of this talk, but intussusception, where the bowel can sort of telescope on itself, can happen. You can get little twists, little adhesions, little internal hernias, little port site hernias sometimes as people lose weight and the little port site didn't heal quite right. So there's a lot of little things. So if you see somebody who's readmitted, first be aware of that really the surgical team should be on board. Okay. The second thing is to remember that post-op bariatric patients, especially gastric bypass and sleeve patients, don't need the routine CAT scan protocol because everything goes through too quick. They need to actually have a drink of CAT scan dye right on the table to fill that pouch. And usually it's just an ounce about a half an hour beforehand and then an ounce right on the table to fill that out pretty well. They don't need that full, quart. Wernicke's encephalopathy, this is some changing gears here, but if you're low on vitamin, it's either B1 or B6, and you give somebody glucose, you can actually throw them into a neurological crisis. They need a banana bag. Any old gastric bypass patient who comes in, before they get a bunch of glucose, before they get D5LR or D5 whatever, their first bag needs to be a banana bag, and we will try to get that once we get protocols put in. We'll get that put on the pathways. But you guys are going to be admitting people for hip fractures sometimes, you know what I mean? Oh, found on the floor after 3 days, came in on, just bear in mind that they need a banana bag. You'll cover them that way to prevent them from having that, what can be permanent neurologic damage. There's an emergency poster that the American Society for Metabolic and Bariatric Surgery puts out, and I'll try to get one of those probably here for the staff room. It's an ER-based thing, but you guys are going to see some of those issues as well. Some of them, there's parts of it that are about management of the band, various things. Very briefly, preoperatively, we do a liquid diet for about 2 weeks on most people to shrink their liver, so that their liver is not in the way laparoscopically. People get fatty liver infiltration, and it goes away. It gets a lot better, at least, with just even a 5 to 10 pound weight loss. And on a liquid diet, most people, it also changes their visceral fat, the fat around the bowels. Sometimes people can get potassium problems with that if they have kidney problems, so just bear that in mind. Usually that's for Jillian and me to worry about in the pre-op rather than, but if you see a potassium of, 6, it's probably more related to being on the table in the OR, which now that we're faster, now that we're an hour or two for most of these operations as opposed to 5-6 hours that they were 20 years ago, you don't see the rhabdomyolysis, you don't see the CPKs and things that you used to. But it can happen, and we are going to operate on some older folks with long-standing diabetes whose kidneys are not totally up to speed. So they can be pretty sensitive on that. We also use a lot of Toradol. Try not to use it in the people over 65. Try not to use it in the people who have, kidneys at risk. But it's such a good pain reliever, so that can be an issue. We do use the OnQ in a lot of folks, those pain pumps that help minimize the need for narcotics. We already talked a little bit about the social stresses. There can be family dramas that play out sometimes with these procedures. There's a lot of family dynamics that get bound up. A lot of people, not as many as you would think, but there is a significant minority of folks with clinically severe obesity who have histories of abuse in the family. It may not even be the person who's having the surgery, but some families have abusive downstream undertones, so that can come out in the hospital. I haven't seen it all that often, but just be aware of it. You guys probably will be more aware of it than me.